Welcome to the Myeloma Matters podcast, hosted by the Multiple Myeloma Research Foundation and focusing on patients' experiences with and perspectives on multiple myeloma topics that matter to anyone affected by this blood cancer. In this episode, you'll learn about autologous stem cell transplantation and why it's considered the standard of care for eligible, newly diagnosed patients. You'll also hear from 4 patients who have undergone stem cell transplantation, sometimes even twice. Please note that every myeloma patient is unique. The information in this podcast is not intended to replace the services or advice of trained healthcare professionals. Please consult with your healthcare team or contact the MMRF Patient Navigation Center at 1-888-841-6673 if you have specific questions about your health. An autologous stem cell transplant is a procedure in which a patient's own stem cells are used to help restore their blood counts and immune system after receiving a high dose of melphalan. Melphalan is a chemotherapy drug that is effective in killing myeloma cells. Unfortunately, in the process, it also kills normal cells. In a stem cell transplant, healthy stem cells, that is, the cells that mature into blood cells, are removed from a patient before he or she receives melphalan. Later, after the melphalan treatment is complete, these stem cells are re-infused back into the patient, where they mature into blood cells. For many patients, studies have shown that a stem cell transplant used after initial therapy offers the best chance for a deep, long-lasting remission. In the past, a person's eligibility for transplant was based primarily on age. Nowadays, age is not a barrier to stem cell transplant. Rather, eligibility is based on the patient's overall health and any coexisting conditions. Because of this, more patients than ever before are considered to be candidates for transplant. All 4 of our guests today, Alicia Wiggs, Jennifer Anseer, Lynn Cella, and Suzanne Wolfram, received an autologous stem cell transplant as part of their myeloma treatment journey. Like most patients, Jennifer, Lynn, and Suzanne received transplants as part of their initial therapy. Suzanne was diagnosed with multiple myeloma in 2018 after routine blood work revealed some abnormalities. She was surprised because she didn't have any symptoms.
I was in the best physical shape that I'd been in because I quit my job to move. And so I was focused on exercise and, cooking and all that. So the cancer was the furthest thing from my mind. And lo and behold, he sent me to the lab 4 times. And I kept thinking the lab can't get this right. There's something wrong.
After additional testing and a bone marrow biopsy, Suzanne was told that she had cancer and that it may be aggressive. Her oncologist recommended a stem cell transplant.
My doctor had said, well, this is the gold standard treatment. We do immunotherapy and then a stem cell transplant. And I said, well, I want to get another opinion. And he said, absolutely.
Suzanne went to MD Anderson Cancer Center for a second opinion, where a myeloma specialist confirmed that a stem cell transplant was her best option.
It was fully confirmed, I'd say late March, beginning of April of 2018. I did May, June, July of the immunotherapy, which brought my levels down, thank God. And then I was ready. Then they tested me and I was ready for a stem cell transplant. So I did that in September and that was that. And ever since then, I've been on Revlimid.
For Lynn, the experience was similar. Her doctor recommended that she undergo a stem cell transplant as part of her initial treatment. After several years of testing and consultations for extreme fatigue and a misdiagnosis of immune-related conditions, Lynn finally learned that she had multiple myeloma.
Towards Thanksgiving, I started having a tremendous amount of neck and back pain, kind of out of nowhere. I was going to a physical therapist, and it wasn't getting better. And I finally went to and had some x-rays done on my spine, and they had noticed that I had compression fractures to my spine and that my T1 vertebrae was in bad shape, and went through the tests, and then I was diagnosed.
Lynn's bone disease was so advanced, her oncology team wanted to be aggressive with her treatment. They started her on immunotherapy right away.
And then at that same time, he discussed with me the stem cell transplant. He said this really the first line of treatment. And as I recall, that was really where they were going. I was not given another option.
Jennifer's case was unusual. She was just 31 years old when she got her myeloma diagnosis. Like Lynn, Jennifer was diagnosed after her doctor found abnormal results during routine blood work, which led her to an endocrinologist and ultimately an oncologist. And like both Lynn and Suzanne, Jennifer received a recommendation from her healthcare team to get a stem cell transplant up front in her therapy. Jennifer's doctors wanted to be aggressive with her therapy, given her age.
And when I went to Texas Oncology for my appointment, the oncologist came out and said, "Your numbers really got my attention," which is something you never want to hear from a doctor.
But not everyone receives a stem cell transplant as part of their initial treatment. Improved response rates to new myeloma therapies have led to differing opinions about the role of stem cell transplant and when it's best to perform the procedure. Stem cell transplant after initial therapy, otherwise known as induction therapy, remains the standard option for eligible patients. But some patients may choose to delay transplant until after they have relapsed from initial therapy. Our fourth guest, Alicia, was diagnosed with multiple myeloma after experiencing dizziness and fatigue for several years. Initially, these symptoms were incorrectly attributed to menopause. Ultimately, her myeloma diagnosis came after doctors performed x-rays and found a large lesion on her hip. Alicia consulted with multiple oncologists to weigh her options. She decided to take advantage of the new advances in immunotherapy that were available and opted to delay her stem cell transplant. After receiving 6 weeks of a Darzalex-based treatment, Alicia experienced pain in her legs. A PET scan revealed that her myeloma was continuing to progress. At that point, Alicia decided to pursue a transplant.
Looking back on it, it's like, the initial diagnosis and the overload of fears and anxiety and looking for a specialist. I mean, if you listen to the specialists that I saw 3 of the top in the world. Each one of them had a different opinion. And each one of them had a different guidance, except for they all agreed I needed a stem cell.
Alicia was hesitant about her stem cell transplant, but ultimately decided it was the right choice for her.
And I already was having so many bone lesions and issues that I wanted to stop it in its track and be in remission for as long as I could. So stem cell was it wasn't that I asked for other choice. Well, I did ask for another choice, right? I tried immunotherapy and I really wanted that to work, but it didn't.
To determine a patient's eligibility for transplant, the healthcare team conducts a number of tests to ensure that the patient can handle the transplant process. Alicia received a full-body X-ray and an echocardiogram, and she underwent tests on her lungs, heart, and kidneys. Patients should talk with a myeloma specialist regarding their eligibility for transplant, as well as the potential risks and benefits of the procedure when deciding whether to include a transplant as part of their treatment plan. An autologous stem cell transplant is a multi-step process. In the first step, patients receive 4 to 6 cycles of induction therapy, typically a 3 or 4 drug regimen, to reduce the number of myeloma cells in the body. Patients then undergo extensive evaluation to make sure they can tolerate the procedure. This involves assessment of their heart and lung function, as well as screening for active infections. Once a patient is confirmed to be a candidate for the transplant, his or her stem cells are collected, a process known as apheresis. Before apheresis is started, patients receive injections to ensure that a sufficient number of stem cells can be collected. During apheresis, a catheter is used to collect the stem cells from the bloodstream. The collection is done over the course of 1 to 5 days. Some patients, like Jennifer, only need one session of apheresis to collect enough stem cells for transplant. Others require multiple sessions.
I didn't even collect enough for one. Oh, what a panic. And then they gave me a shot in that night, and then I have enough for 5.
Some people have side effects after treatment with these types of medications. These can include bone pain, headaches, nausea, and diarrhea. After the stem cells are collected, they are frozen and stored until the patient is ready to have them re-infused. Even patients who choose not to have a transplant right away can have stem cells collected early to ensure that they have enough when they are ready. Before stem cells are re-infused, patients receive a chemotherapy drug known as melphalan. Melphalan kills most of the myeloma cells left in the body after induction therapy, making way for the collected stem cells to be infused. The day after melphalan is given, the patient's stem cells are thawed and re-infused into the bloodstream. This is done relatively quickly over the course of 30 minutes, depending on how many bags of stem cells are being re-infused. These re-infused cells migrate to the bone marrow, where they begin reproducing new blood cells, typically beginning within 2 weeks of transplant. A stem cell transplant can be performed as either an inpatient or outpatient procedure. When conducted as an inpatient procedure, the patient stays in the hospital throughout the process. When it is performed as an outpatient procedure, the patient stays nearby and makes daily visits to the clinic. Many centers provide housing that is set up specifically to meet the needs of transplant patients. Alicia needed to have her procedure done inpatient because she was part of a clinical trial. Being inpatient also ensured that both she and her husband had the support they needed, which was especially important because of the higher toxicity of the drugs used in the clinical trial.
The mental, physical responsibilities, like you're saying, are a lot on a caretaker. And even though I really wanted outpatient, we now talk about it, and he did not want it. It was kind of a back and forth because my desire of having the place to relax and get away from 2-4-hour vital signs and all of that, he was very happy to have those things and to have the support of the medical staff there.
Jennifer, on the other hand, chose to have her transplant done as an outpatient procedure.
I actually, having talked to other people that have had it, really appreciated that it was outpatient because I feel like it got me up every morning and out of bed and in the shower and walking there. And I don't know that I would have done that as much if I had been in the hospital where I didn't have to do those things.
Both Lynn and Suzanne also opted for the outpatient procedures. However, after their chemotherapy, both experienced significant side effects that required them to be hospitalized. Suzanne was also hospitalized for dehydration resulting from nausea and vomiting.
I was pretty uncomfortable. I was very, very, very nauseous, and to the point where it was intractable nausea. So I wasn't able to eat well, and the chemo changes your taste buds, but I was extremely nauseated to the point that they finally put me in the hospital so they could do better control. And I had some back pain associated, but it really wasn't for the back pain. They put me in, for that, for the nausea, and then they could give me IVs.
Side effects following stem cell transplant are common due to the high-dose chemotherapy, which kills many of the remaining myeloma cells but also kills healthy cells in the gastrointestinal tract. This can lead to nausea and vomiting. Some patients, like Alicia, experience mucositis or painful sores in the mouth. These symptoms can make it difficult to eat, which can lead to weight loss. Other possible side effects of transplant are diarrhea, low blood counts, hair loss, and fatigue.
I expected to be tired, I didn't expect to be quite that tired, but, bone marrow had been wiped out. So, building back your blood cells and everything. So it didn't surprise me. And, it was manageable.
Patients are also at increased risk for infection following a stem cell transplant because the high-dose chemotherapy kills healthy disease-fighting cells as well as cancerous cells. It is important for transplant recipients and their caregivers to carefully follow their healthcare team's instructions on minimizing infection risk.
So we had to totally clean, sterilize the apartment, and then they also have you eat. Your diet is very important. That you can't eat fresh vegetables or fruit and all of that. It all has to come in cans and be very well cooked, because of organisms and infections and all of that. We had to clean the sheets. No one could be in my room with me. I had to be by myself when I slept, and the bathroom and all of that.
Avoiding infection risks can be challenging during the months immediately following the transplant. Friends and family may want to visit after an important medical procedure.
My dad really wanted to come, but got a cold and was, really scared he was going to give me something. So anybody that felt a little off or not as healthy, that was a challenge for them because you want to see your daughter, but you also don't want to give her a cold that could end up in the hospital. So everybody was super careful about how they felt, washing hands a lot.
My husband and I laugh about it now, but sometimes he would take my temperature 3 to 4 times a day. And I had no temperature. But again, he was my caretaker, and that was a fear for him.
10 to 14 days after the transplant, newly formed blood cells can be found within the patient's blood as the infused stem cells begin replacing those that were lost. This process is known as engraftment. Over time, the blood counts will continue to increase as new healthy red blood cells, white blood cells, and platelets are produced. The road to recovery after a stem cell transplant takes time. Some patients take longer than others, depending on their underlying health and the side effects they experience.
I know I went to a wedding, March, April, May. 4 months later, I went to my nephew's wedding. I still wore my wig because I still did not have significant hair growth. I was still very thin, but I was able to go to the wedding, have a good time. So I'm going to say at about 4 months, I actually felt like putting makeup on, putting a dress on, going out into a crowd. I was smart about hand washing and food safety and that type of thing, but I went out into the public and everything. I felt good. And then probably 2 months after that, my hair started to really grow in and I stopped wearing the wig.
Many patients experience meaningful and long-lasting responses after autologous stem cell transplant. Alicia was found to be minimal residual disease, or MRD negative, after her transplant, and has enjoyed more than 3.5 years of MRD negativity, with continued Revlimid maintenance therapy alone. For Lynn, the M protein levels continued to drop with Revlimid maintenance therapy. After 1.5 years, her oncologist recommended she stop taking Revlimid, and her disease has remained undetectable for 8 years. Ongoing monitoring, which includes blood tests, imaging, and bone marrow biopsies, is recommended to determine the number of myeloma cells that remain after transplant and how these levels change over time. Jennifer's initial biopsy 6 months after her transplant showed that she was in remission with no cancer cells detected, but she continued regular monitoring, and nearly 3 years after her first transplant, her M protein values started to increase.
My doctor at the time kind of threw out a couple options. I want to say that we tried thalidomide again with the new version of steroids, which is once a week. And that wasn't really doing a whole lot. So he wanted to be a little more aggressive. And, we talked about a second transplant since the first one worked so well.
Jennifer's transplant team had collected enough stem cells during her first transplant for another procedure, so she did not have to undergo apheresis a second time. She had a second transplant 4 years after undergoing her first. This was followed by 2 years of maintenance therapy. She currently sees a myeloma specialist every 3 to 4 months, but she has maintained disease control for more than 11 years at this point.
So my myeloma since the second one has been extremely slow moving. I joke with everyone and I say that we have been coexisting peacefully in my body.
Whether they are performed upfront or later in treatment, stem cell transplants provide durable and meaningful responses for many people with multiple myeloma. Studies suggest that when transplants are performed early, that is, right after initial induction therapy, patients can expect longer periods of remission than if transplant is delayed. But the view of transplant timing in myeloma is evolving, and many patients choose to delay a stem cell transplant for personal reasons.
The anticipation of not knowing how you're going to feel and what's going to happen. And then once you're in the throes of it, you deal with it. And it's not anything that I couldn't handle that I think most people can handle. And probably some people handle a lot better than me.
All of our guests emphasized that the decision of if and when to pursue a transplant should include a discussion with your oncologist, but should ultimately be dependent on your own personal preferences and priorities.
To be educated, first and foremost, like ask questions, advocate for yourself, trust your gut is one of my biggest ones. You know, there's so many times that a doctor wants to do something and you just have this horrible feeling about it. And I would say just go with your gut. I have some friends that have done the transplant and others that are like, nope, I don't want to do it. It's the last thing I want to do. And I completely understand. But I personally have had crazy good response from it. And it's given me a lot of time that I honestly didn't think that I would have. You know, at 31, I didn't think I would hit 40 with this. And here I am, 47.
Would I have chosen to have a stem cell? Would I have chosen to have chemotherapy? Would I choose to have myeloma? No, I don't choose any of those. You know, I don't want any of them. But when you see what will give you the longest remission time, will give you the most significant remission, that's what I needed and what I wanted.
Let's hear more now from Alicia, Jennifer, Lynn, and Suzanne as they join the MMRF's Mary DeRome in a roundtable discussion on their perspectives on what the transplant process is like and how it has shaped their myeloma journey.
Hi, everyone. First, let's talk a little bit about how did the topic of stem cell transplant come up as a treatment option? And what sort of tests did you have to undergo to determine whether or not you were a good candidate for this procedure? Lynn, let's start with you.
Well, I would say that stem cell transplant came up right away. It was one of the first things my oncologist, he was my hem-onc oncologist, said, this will be part of your treatment. This is, at the time I was diagnosed, it was the standard. So there wasn't much decision making there. And I felt very comfortable with him. So I was diagnosed at, I was 59. So they had to make sure that my heart was strong enough, my lungs were strong enough. They did, you know, also the general physical, but I did have pulmonary function tests to make sure that my lungs were working properly and I had, you know, good lung capacity. And they did echocardiogram or possibly a MUGA. I don't remember exactly, but that's just something, you know, more extensive for testing the heart. And I was good to go. So I was cleared and ready to go.
So does anybody else want to talk about their experience and when they were first diagnosed and how stem cell transplant kind of came into the picture as something that you'd be undergoing? Jen, how about you?
So since I was diagnosed in 2006, there weren't as many drugs out as there are now for myeloma. So it truly was standard of care. They not only pushed an auto stem cell transplant, they were also trying to talk me into doing an auto immediately followed by an allo transplant, kind of tandem. And I ended up doing a ton of research, talking to people that had had them. And honestly, it just kind of came down to a gut feeling where I decided not to do the allo. So I just did the auto transplant, and it was very common even then for people to do 2 autos back to back or an auto allo back to back, just because lack of other resources. But eventually I just kind of came to the decision that we would try the auto, since I had such good response to the thalidomide, Velcade, and Dex I was on. We were hoping I would have excellent response to the transplant, which is what happened.
I would add to that, Jen, they recommended, so in 2014, after I had my workup and at the place that I was going to have my transplant, they said I was a good candidate for a donor transplant and worked me up for that. And I was told that the donor would give me 7 years if I had the donor after the auto, and that could be possibly 25% chance of cure. They did not really discuss with me the other issues of donor transplants, and I discussed it with my family and my sister, lucky enough to have a sister who's in the medical field. She discussed it with some other people she knew, an oncologist, and he was not on board, and he recommended that I have some second opinions, which I did, and I decided against the donor, and I am now 8 years out without the donor. So I was happy I made the decision I did. And as a matter of fact, I had been told that multiple myeloma patients do not do as well as other patients with donor transplants. I mean, if that is an option that you have to have, you do what you have to do. But that happened to me as well. And this is still in 2014.
So certainly the allo transplant was, as you mentioned, Jen, one of the only treatments, right? The allo and the autologous stem cell were really among the only treatments that were available back when you were diagnosed in 2006. And starting in 2015, that's when many drugs began to be, approved for multiple myeloma, 1 per year or even sometimes more than that, right? So now there are many more options that are actually safer than an allo transplant, and allos can be pretty debilitating and not so great, and they've really sort of fallen out of favor in the medical community in myeloma over the course of the years, because now there's so many better options available for people, which is actually good. See, and you guys were all, like everyone who's here with me on the call, you were all diagnosed relatively young. Like none of you were diagnosed when you were in your 80s or even in your 70s, right? So that's when transplant begins to be potentially not an option for people who are, it's not, there's no age cutoff, but it can be cut off due to frailty of patients. And that's usually what they look at, the frailty index, like how healthy is the person overall and how well can they tolerate a stem cell transplant, because they can be a little bit overwhelming. And we'll talk a little bit more about that. As you guys know, because you've all been through this, patients who undergo a transplant usually require a lot of help and support just to get through the procedure. So Suzanne, tell me a little bit about the level of help that you needed. How long of a commitment is it for a care partner, and who you relied on for help throughout your transplant?
Well, I was very fortunate. After I also had a sister who was a diligent researcher. I actually consulted with 2 oncologists. I'm in Austin, I went to one here who I use, and then I also went to MD Anderson. I'm also a breast cancer survivor, so I was already a patient and familiar with that. So in talking to both of them, they laid out the pros and cons and kind of the journey. And I like to tell my family, and one of the doctors explained to me, and it's still the case, that multiple myeloma is not a curable cancer yet, but it is a treatable cancer. So it's a lifelong journey with myeloma. And knowing that going into it, once I researched the stem cell transplant, fortunately, there was a unit here in my town that had only opened up 3 years prior. So met with those doctors and became very confident in their ability. And I was going at it with outpatient believe it or not. They said, I was in great health going into it. And they said, however, you will need help. So I did immunotherapy for 3 months leading up to my stem cell transplant. And I did great through that. I had a little nausea, a little tiredness, but really it wasn't much of a lifestyle change, to be honest. I drove myself. I was able to take care of myself the whole time. So I was really fortunate. I think going into it, being so healthy and not having other underlying conditions really served me well. Once I knew that I was going to have the stem cell transplant and I was ready, it would require, although they wanted to do the whole process, collection and whatnot, I did outpatient, just in case. Following that, I might have issues, particularly once they collect your stem cells, they hit you with the chemo, the hard chemo. And so I called on my sister, who generously flew down because my husband was still working. And he's the breadwinner, and he needed to keep our insurance and keep things going. So we were actually secluded in an apartment at the time. We were in between homes, and it worked out beautifully. They stripped down when they got when he came in the house, and they had to use a separate bathroom, and we sterilized. Back then, I don't know if they still require, but we sterilized the whole, apartment and cleaned, and then you could only eat certain foods, and they give you lots of instruction, and we just managed through that. But I do think having a caregiver, and I had friends drop off meals that would meet the requirements, the stringent requirements during that time. And then beyond the stem cell transplant, I did get sick and did end up in the hospital for 10 days. I tried to do it all outpatient, but my sodium levels dropped to a alarming rate. And so I went to the hospital and stayed there they make you stay for 10 days. I thought I'd be in there and out. And then my sister stayed with me, and there's a 100-day isolation following that, which now that we've been through COVID, everyone understands isolation. I mean, I'm sure everyone had the same reaction I did. Wait a minute, I just got done with all this. I don't want to go back in. Anyway, I was blessed, so fortunate. So for me, I rallied fairly quickly after the stem cell transplant. I would gradually walk. You could walk outside and, start to get your physical activity built up. So once I was about another 3 weeks after my sister left, and my husband and I were able to handle it on our own. So I think it really helps because particularly if something goes awry, as in my case, and I needed to go to the hospital, she had to be my advocate because I went to the ER and I was in pretty dire straits and I wasn't getting the attention that I would on the VIP myeloma floor. Wasn't there yet. And it was on a weekend, of course. So I think it's really helpful to have someone that can, and you could tag team, people, but they all have to obviously be healthy and willing to stay in a confined environment with you. But there are a lot of blessings that come from that too, through that. Sometimes I was thankful that I had the isolation and didn't really want to go back to the real world because you're totally focused on yourself and you can really, it gives you time to reflect and inward, and there's a lot of blessings that come from that.
That's a great take on that whole thing. The way think of it as at least parts of it, think of it as a blessing.
Thank God for sisters. I was going to say, Suzanne, I had the same. Lucky I had my sister, and she was my caretaker when I had my transplant. The center that I had it at Hackensack, New Jersey, you could choose to be in the hospital, or you could choose, they had apartments set up. So I chose the apartment setup. My sister also flew in. She came from Portland, Oregon, and she stayed with me throughout. And she would transport me during the day when I had the chemo, and then they gave me my stem cells. They engrafted during that period. And in the evening, we would go back to the apartment. And she made sure that I had all of my medications, and she forced me to eat and made sure I had a mouthwash that helped me from getting sores in my mouth that I had to do diligently about 6 times or 8 times a day, and it tasted terrible. And she would force it on me, but that I'm glad that she did because I didn't have any mouth sores. They also had me chew ice during my infusion, so that was not a problem. I had another problem called engraftment syndrome, but we can discuss that later if you like.
We do have a section where we really want to talk a little bit about side effects and the things that you guys sort of went through. So I'm going to go to Alicia now. So Alicia, you were diagnosed when you were 54 and you actually were on a clinical trial, right, for a period of time when you were first diagnosed, so that when you did your stem cell transplant, you actually had to do it inpatient in the hospital because of the trial that you were on. So tell us a little bit more about that.
So there was no choice. I had mine done at MD Anderson, and they did not do outpatient. I think if you really, really fought for it, you could have outpatient, but you had to do just a typical transplant, and they had recommended a clinical trial for me, and the clinical trial was not an option of doing outpatient. And I was one of those ones who really wanted the outpatient experience. I just feel like going home to my own bed, and not even my own. That would have still been living somewhere else, but my own apartment and having your own space. And I was actually inpatient for 21 days. And during that 21 days, every 4 hours, vital signs round the clock really got old. I, asked to space them out, and that did not happen. So 21 days of every 4 hours, someone coming in, they have their job to do too. And there was a lot of that. So for me, inpatient, that was a little challenging in that way. And you were not allowed to leave the floor. So when you did walk, the only walking you could do would be around the halls. Mile after mile of walking in the halls day after day. Once I was released, I still needed to stay in Houston for another 14 days, and then I could get out, and walk with the mask on, which the mask is routine for so many people these days, but that was a little odd back then. But you could walk in nature, and that sure was nice to be outside. So in my mind, an outpatient where you could go out and outside, but the clinical trial required being in hospital. It was a rigorous protocol, multiple drugs, and they caused lots of mouth sores, a lot of weight, but no one was real concerned. I did gain the weight back, as they knew I would. When I left, I felt so thin and so hungry and really worried that my appetite would ever return. But the transplant team was not concerned, and I went home, and slowly I was able to think of strange things that I could eat and would be hungry for, such as Fritos and bean dip. Don't even know where that came from. Wasn't healthy, but it was something I could eat. And I began to eat and gain my strength again from getting out in nature and eating different things. But being inpatient, it seemed like forever for me, but you don't feel great. So I slept a lot, and, there wasn't a lot to do. I slept a lot and watched some TV, and the 21 days went by.
So it was 21 days that you were actually in the hospital, and then you had to stay in the area for another 14 days after that.
Correct. I had to stay in the area for another 14. I live 5 hours drive, and so I was then able to go back home to my more rural area after the 14 days. But we found an apartment, an Airbnb type apartment, because Houston did not have a apartment complex for you to stay in. So a lot like Suzanne, we had to wash everything, clean, all of everything. My husband was my main caretaker, but again, he was, working. So I had several friends that came and stayed to relieve him at different periods of time. And yes, we made sure they were well. And if they felt the slightest tickle in their throat or anything, they wore a mask. But a lot of support from them. And
For me, it was interesting how a lot of the friends just really showed up and were very helpful in that I hadn't seen some of them in years. And my husband put out on CareBridge that he needed some help. And these friends stepped right up and gave of themselves and their time and were very, very helpful.
Everyone knows that you have to really take some very, very strong chemotherapy in order to have a stem cell transplant. And as you mentioned also, Alicia, there's other drugs that you take as well. So I'm just wondering if any of you have experienced any long-term complications from having undergone your stem cell transplant. Does anybody really think about some of the things that they've had to go through since the stem cell transplant that might have happened because of that treatment?
Well, I had a short-term problem, which resolved, but no long-term problems.
And I think I don't have any long-term problems from the stem cell transplant. I do take maintenance, and I do have some side effects from my maintenance drug long-term, but my actual stem cell itself, my hair grew back, my weight came back on. No known side effects from the stem cell long-term.
Interesting for me, I did a different immunotherapy leading up to my stem cell transplant. And the one of the therapeutics that I had, they checked out my heart because it was known to impact the heart. And so after the stem cell transplant, not too long after, I would say once I was in recovery and all, I started to develop heart palpitations. And I did have an episode that took me to the ER. I thought I was having a heart attack. But anyway, met with the cardiologist and everything checked out fine. But I remembered that, and that was, not often, but it was an occurrence during a certain time frame. And so now that I'm starting new treatment because I'm coming out of remission, that was a factor in not using that particular drug. I responded really well, but one of the oncologists that I spoke with said, if you had a episode, let's reserve that and use another treatment therapeutic. I was on maintenance as well. I've been on Revlimid as well. And the long-lasting impact, and I don't know if it was, I'm assuming it was from the chemo and the Revlimid, but I've had gut issues ever since. I've always been a good eater, always could drink dairy and everything else, and I have had ongoing gut issues, diarrhea, different things. So I do feel like that was probably part of the stem cell transplant, the chemo that I undertook, and the treatments beyond.
Maintenance could definitely, especially with Revlimid, it has pretty well-known GI toxicity, so.
I'll add to that. I have had, and I did not attribute it to the transplant, but I have had stomach issues as well. I get nausea, intermittent nausea. So it's, nothing I can't live with. And if it gets bad enough, I take a little something for it. But my stomach definitely has changed. And I get full faster. I eat small meals to overcome that.
Everybody's on a number of different medications, and it's hard to really pin down exactly where the symptoms come from, based on what you happen to be taking at the time. But so, Jen, let's talk a little bit about your case, because you were diagnosed fairly young with multiple myeloma at 31 years of age. And that was back in 2006, where there really weren't a lot of great effective therapies for people with multiple myeloma. So when you were diagnosed, did your doctor talk about treatments that you were going to go on, and anything about fertility issues with you regarding that?
Yeah, it was kind of very matter of fact of what I was going to go on, because there just weren't a lot of options at the time. They were really excited that Velcade had come out, so I could do this cocktail of 3 drugs instead of 2. But we did talk about fertility issues. I want to say it was before the stem cell transplant, but it was quite a while ago, so I can't remember exactly, but it may have been before I really started getting into the meds. I had never desperately wanted children. I think I'd always kind of been on the cusp of that decision, unsure. And then when I was diagnosed, the statistics then were way worse than they are now. You had a 40% chance, I think, of living for 5 years. There was a 20% chance of living for 10 years. And in my head, I just couldn't think about having a child that I would then have to leave within 10 years. Like, the statistics were just so bad. So I just kind of refused it. I thought, I just didn't even think I was going to hit 40, maybe 35 if I was lucky, but I don't think I would hit 40. And do I want to throw a child in there at this complicated? So I refused any of the fertility, because they did talk about harvesting my eggs.
That must have been a very difficult time. On top of everything else, you have to worry about fertility, along with your own survival. Let's talk a little bit about the process of stem cell transplant. I'm sure that you all had conversations with many doctors about what you were going to be undergoing. And was there anything about stem cell transplant that was very scary to you? So I remember, my mother was diagnosed with multiple myeloma when she turned 80 years old. And the only thing that she would ever talk about was, I'm not going to have something done that I'm going to lose my hair. And I'm like, Ma, you're 80. They're not going to give you a transplant. So thinking about things like that, what was it when the doctors were telling you, preparing you for what you were going to have to undergo? Was there anything in particular that you just had a lot of trepidation thinking about?
Definitely losing my hair. That was a very frightening prospect, because my hair was my pride and joy. I could always wear my hair. My girlfriends were always saying, you're so brave, because I would change my hairstyle all of the time. And I had thick, very nice hair. So that was definitely, what am I going to look like bald? How are my children going to perceive me? Other people are going to perceive me. They're going to see that I have cancer. My husband, will I be attractive to him? Those things. And I think focusing on that maybe helps you not focus on some of the other things that are equally, scary, or maybe scarier. The other thing was really, how sick am I going to be from the medications and nausea? Am I going to be nauseous? And you've seen things depicted in movies or on TV, and those were my fears. And dying from it just did not cross my mind. But in the back of my mind, there was potential, but they did a very good training at the center I was at. They had a full day where they had a doctor come in, a nurse come in, nutritionist come in, and a pharmacist come in, and you brought your family members, and they went over everything. And the best part of that was the pharmacist, when he talked about, this is how we're going to control your nausea. There are many things in the arsenal. So that helped tremendously, and just prepare me for the process.
That's good that they really brought in your entire family and many specialists and talked about everything with everyone, so that there really weren't, hopefully, no surprises, right, after all of that. Alicia, how about you when you were learning about transplant? Did anything stand out for you that you were not looking forward to?
The anxiety and the buildup and just the fears of what it would be. And again, finding out that I would need to be inpatient instead of outpatient, which I preferred. Just the fears. And I really do think that by the time it was over, I was sort of like, oh, okay, I did it. There were a lot of things to it that get so hyped and so fearful because of the hype that, like I said, when it was done, I was like, wow, I did it. I was able to do this. And even though I had a lot of extra things, the nausea, the mouth sores, the diarrhea, had to work up for, a secondary infection, many things, but it was kind of like you. I came out and I said, oh, I didn't die. And it wasn't as bad as I thought it would be. For me, it was not as bad as the anxiety had worked it up in my head. The fear, the magnitude of the elephant, of the stem cell, and then, getting my cells back that day. Well, I had a birthday party. We brought in cupcakes, and there were the priest blessed my cells, and it was done. It just was sort of almost anticlimactic. Okay. And the healing began then after that, right? I felt like there was so much doing up to the preparation time, the testing, the collection, and everything was and then once the transplant was done, it was time to heal. I even worked with a therapist for a little while, working through my thoughts and my trauma from the time. And like you said, I spent a lot of time on myself. It was a lot of inner self-care time. And then I was cleared and COVID came along. We've all been in that isolation time, learning to take care of yourself in quarantine.
And we've talked a little bit already about maintenance therapy. So I think that all of you are relatively familiar with Revlimid and being on that for maintenance, which a lot of people go on after they have their stem cell transplant. So one of the side effects that can occur when people are on Revlimid for a long period of time, and they actually had a discussion about this at the recent American Society of Hematology meetings that took place in New Orleans a couple of weeks ago. And I remember going and seeing a couple of talks about what they call secondary cancers or second primary malignancies, and which can be an offshoot, relatively rare offshoot of people who were on Revlimid for a long period of time. Suzanne, when you were on Revlimid, did your doctors talk to you about that at all? And what did you think about that?
Well, they did mention that it was a risk. And I'd already survived breast cancer. Interesting, after my stem cell transplant, not long thereafter, I guess it was like a year after, they did find basal cell on my nose and on my forehead. So I underwent Mohs surgery for skin cancer, pre-skin cancers. And I've been careful ever since on that. But quite honestly, having gone through breast cancer and then through myeloma, I was like, I'm going to handle whatever's thrown my way. Yeah, I'll tell you, go back to the question regarding the stem cell transplant. My biggest fear was collecting enough stem cells. You work all up to it, and it's out of your control. You don't know how many they're going to be able to collect. And as Alicia pointed out, you anticipate this big, process. I was fascinated by it, that they actually, it's like a blood transfusion, and they actually took my cells and spun it, and then your stem cells rise to the top, and they collect those, and then they put your white blood cells and red blood cells back in you. I was fascinated by the whole thing. I thought it was amazing that we have this available to us. And then, of course, I had to pray for the guy that carried my stem cells. I said, what do they do with them? They had to carry him to another town, and he literally put them in a canister in a car, drove it to the other. So I'm talking to the nurse that handles all of this, and I said, well, is he a good driver? What if he gets caught on the road and my stem cells are all over the highway? I said, after all this, this is, treasured stuff you've got there. Anyway, so we prayed for him to deliver them there and pray for them to get back, to put back in me. That was my biggest fear of the whole event. But it all worked out great.
If you don't have your cells, then you don't have the transplant. So, that's arguably the most important part of the whole thing. So, Lynn, you were also on Revlimid, right? Or you're still on it? So did your doctors?
I was on Revlimid. They put me on. Instead of having the donor transplant, which was a bit aggressive. They put me on Revlimid. And that was when I had my consults for that, my second opinions from two doctors. They said, why are they thinking of doing this? And why are you not on Revlimid? So I did go on Revlimid. I was on it for a year and a half. And then it started to affect my bone marrow. My blood cell counts were going down. And so I was taken off of it. And so for 5 years, I've not had any medication.
I did a year and a half also, Lynn. They did not talk to me about secondary cancers, but I had been doing a lot of research and saw that was there and an option. It was after my second transplant, and I was just done. Like I didn't want to have another cancer. I didn't want to have another, I had 2 transplants. I was good on that. And I just said I wanted a break. And my doctor wasn't very happy about it, but it's lasted 10 years.
Sometimes, Jen, you know, and we all know you have to, you hear a lot of things. Certain doctors have certain approaches, whether they're at a research center. There are a lot of different drugs out there. There are clinical trials out there. And as a patient, it's very hard to decide. It's almost there's too much. I mean, it's wonderful that there are so many options now, but it's very, very difficult to decide. And sometimes you have to just go with your gut, and you have to take control. You make a decision, and and that's that. I admire you that you did that, and I also was not told about these the Revlimid and the effect of a possible secondary cancer.
I'm on Revlimid now. I've been on it for about 3.5 years. I've gone down in dose and down in dose. I'll begin to feel, more frequent diarrhea, mood swings, some of the other GI issues with nausea and that type of thing. And when I go back in, I'll think, oh, this is terrible. It's affecting my daily life. What can I do? And he just drops it a little bit more, drops it a little bit more. So I'm going down another little dose now, but I think for my physician, it's such a, not a crutch, but it makes him feel better, and myself too that I know that I am on some type of maintenance, even though it's such a low dose at this point. But secondary cancers are not focused on. They are maybe presented, but not really focused on. And when I do a yearly physical, they look a little closer, yes, for both melanoma or any type of breast cancer. Those are really the only two types that I've really been maybe checked a little further for the cancers, and they've watched my blood work, I'm sure, for anything else they might see. To me, the Revlimid just gets to be more of a daily life, more than the second. I mean, I know the secondary cancers are an issue, but in the beginning, I was like, oh, this is no big deal. But it gets a little harder to tolerate with time.
There are many drugs, that treat cancer that have side effects. You weigh it out. Well, is the benefit worth the risk? And for me, the benefit outweighs the risk. And there is no perfect drug. And many of these drugs have side effects. So, that's something I think that we all live with. And frankly, other people who are treated for cancer and other illnesses. I think that's just, there is no perfect medicine.
So speaking about risk benefit, all of you have undergone at least one stem cell transplant, right? Some of us, Jen, have undergone more than one. So thinking about your experience in having a stem cell transplant, and then thinking about what you think it may have brought you, the gain that you may have gotten from a stem cell transplant, if you were to talk to another myeloma patient, what would be your advice if they were sort of trying to decide whether or not to have a transplant or not? What would you say? Alicia, let's start with you.
For me, I see that there are new and upcoming things, and I think in 5 years, it would be a totally different story. I mean, I was diagnosed 3 years ago, and I heard yesterday that's the olden days. So things are changing rapidly, but I do still think the tried and true, the longest term remission to allow the time for these drugs to catch up with my disease and be my next choice, the stem cell got me there. I'm 3.5, almost 4 years in remission, and it was because of the stem cell, I feel. And it gave me a longer term of disease-free, so that more drugs can be discovered and more, the next treatment can come along that could be the cure and keep me there until that time. I feel like it was part of the the disease, the process. All the doctors, I saw, very, very good, world-renowned doctors, and they all agreed that the stem cell was the thing to do, like I said, especially 3 years ago, but it was successful for me, and it has kept mine in control, so I'm happy that I did it. But I know it's a big choice, and I think that people have a few more choices these days for sure, but definitely there's no magical combination yet. The stem cell is still sort of the pinnacle of treatment for the standard. The gold standard goes back more often to the transplant and gives you a longer promise. CAR T and all the bispecifics and all these things are wonderful, and I'm ready for them to work all through them, but it's coming. So this gave me more hope and more time to get to those.
Suzanne, how about you?
Well, for me, I had high hopes for the stem cell transplant. I really thought I was going to be in remission longer. And like I had mentioned earlier, I'm climbing out of remission. I've reflected on that because I'm entering into new treatment, and I'm going to be entering immunotherapy after discussing with 3 different oncologists at 3 different, well, 2 of them were research hospitals, excellent people in their field. And we talked about another stem cell transplant this go round. And from what I've understood is after you have one, and Jen could speak better to this than I can, but after you have one, then your hope for remission or your amount of time in remission is reduced almost in half the second time around. Well, I was 4 years out and it started climbing. So, I wonder, I've talked to other patients that have done just the immunotherapy, and it did for me. It brought my levels to less than 1%. However, come to find out, I think I have a more aggressive type of myeloma, as you learn. And I think each patient needs to look at your health and where you are. There are benefits, I think, also having gone through it, that I was younger and stronger going into it. I think it would become more difficult to do a stem cell transplant had I had other health issues going on, or I might have been older. So in that regard, I think time is on your side, youth is on your side with a stem cell transplant, I would imagine. Every therapy, you just make the best decision you can. You weigh all the pros and cons, and just know that there are more therapeutics, as Alicia mentioned, on the horizon. And it's really just trying to keep buying more time until we get that magic combination that works for each of us.
I would not want to advise someone on doing one thing or another, certain type of treatment over another treatment. I would just say, and there are, each person's myeloma is different. There are 12 different subtypes, and people are different stages of their life. And I would say get as many opinions, as you can, or some good opinions, and then make a decision from there. The one thing that I was just thinking about as we're all talking is it seems like all of us have access to good health care. And, it makes me think of other people who may not have the choice to have 2 and 3 opinions. I was able to travel to a center in New York for one of my opinions, and I went into New York City from New Jersey, and I was lucky to see some very good people. It's a tough one because there are so many options. We've been lucky from that standpoint.
Okay, so let's talk about your case a little bit, Jen, right? Because you you alone among all of you have had 2 stem cell transplants, and that is probably partially because you were diagnosed so early on when there really wasn't that much else that you could do aside from having a transplant. So can you tell us, Jen, your experience, like how far apart were your transplants, and was the second transplant in any way different from the first? Was it harder? Was it easier? Any information like that?
Yeah, my first one was in 2007. I didn't do any maintenance after. They specifically said, we'll give you a break. 2009, 2010, my numbers started kind of slowly rising again. We thought about going back on thalidomide. I think I did that for a little bit, and my numbers still were just like slowly going up. It truly wasn't very aggressive, but I did find an expert at the time and talk to him, and he said, if you had such good success with the first one, it almost been 4 years, yeah, I would go ahead and do your second one, because again, that's when tandem was kind of a big deal. They definitely weren't tandem because people were doing them literally back to back, but they were pretty close together. I definitely don't regret doing the second one. It was interesting, a few years later, I went to see another expert, and he was like, I don't know that you should have had that second one then. And it really threw me off for a while, because I was like, wait, did I waste that one? Should I not have done that one? It just truly messed with my head for about a year. My husband reminded me, he's like, we went and talked to another expert who told you to do this again because you had such success with it. And I've had 10 years of, I wouldn't call it remission because my, M spike is still there, but of no medication. So for me, it was totally worth it. And again, it's personal for everyone. And I personally, I would do another one if I had that opportunity, just because I've had such success. And I would rather hit me hard for a few months, I'll be down. And then if I can have a few years without medication, then yes, I will take that. And I know I have friends that are like, no, I don't want that. I'll take the meds for years. So it's just kind of a personal choice. I was a little older for the second one, so the recovery time was a bit longer. I want to say with the first one, I was probably back to work half-time in about 2 months. I was pretty young and I didn't have any complications. I was super lucky with both transplants. They were both outpatient. I didn't have to stay in the hospital for either of them. And for the second transplant, it took me a little bit longer to recover. I probably was off for about 3 months and then started going back to work. But luckily I had friends, that were there. And in July of that year, we went to Peru. I was definitely ready to go after that.
We've talked a little bit about, how much the field of myeloma therapeutics has advanced over the past 10 years. And there are so many more choices available to patients now, even when they're newly diagnosed. Some of these really, really effective medications like Darzalex have really moved up into the front line, so that even newly diagnosed patients many times are getting a quad therapy, which is really, for many patients, very, very effective in bringing their disease down. There's been some recent trials that have been done as well, following patients who have been on RVD, so Revlimid, Velcade, and dexamethasone for long periods of time. So that they started off on that therapy, and then some were transplanted right away, as most of you guys were, right? And then some people just stayed on the Revlimid, Velcade, and Dex just for a long period of time, and then perhaps when their numbers started going back up, then they were given a transplant. And so they looked at the length of time that patients were able to stay off of their therapy or just stay on maintenance after having their transplant. So there's been some question, and we had this determination trial that came out last in June at ASCO. There was a big presentation in a room that seated probably 15,000 people if you were going to put all the people in there. And they were talking about this study, and they found that early transplant and late transplant for most patients did not change their overall survival at all, but it did definitely reinforce the idea that early transplant is standard of care for the longest period of time that patients stay disease-free. And that's true for pretty much all patients, unless you're an African American patient. They didn't really see the benefit as much of having an early stem cell transplant versus a later one. So thinking about that and thinking about all of the choices that are available now to patients, if you were to be newly diagnosed now and there were many more options available to patients, do you think that you would still have a transplant now, and thinking that it's the standard of care, or do you think that you might want to put it off until later and just see what else might come along therapeutically that might help? Because I think that a lot of people are thinking that transplant may not be the standard of care in just a few years, although we'll have to see what the data says from the trials that are ongoing. So Lynn, what do you think about that? Do you think that you would still have it up front if you were diagnosed now, or would you wait?
I'd really have to think about it. I'd really have to research the information. I rely a lot on my oncologist, who's not a myeloma doctor. He's kind of been the quarterback for me, and his recommendations and who to talk to. I think I would definitely consider having the transplant. I mean, it's hard to say, knowing what I know now, and I'm 8 years out. I hope for me that I've lived long enough, and obviously I've lived long enough. There's been a lot of new drugs, and there'll be a lot of treatments as my numbers climb. Again, they will. I anticipate that at some point in time. But I think I would probably opt again for a transplant.
Mm-hmm, mm-hmm. Suzanne, what about you?
Well, you asked the question, you posed it if for a new patient, for someone recently diagnosed, right? I think if you're young, you don't have other underlying conditions, and your doctors are telling you, yes, you're a good candidate for a stem cell transplant, I would encourage you to do it. It is manageable. It's a detour in life, but it's not a end-all to end-all. You're up and moving again. So I think it just depends on the individual and the state of your health and your support group, as you brought up before. If you're surrounded, have people that you can rely on to help you through it during those tough times, I think I would do it again if I were posed that question in good health. I think as you get older, and if you have more health issues to consider, your doctors certainly should take all that into consideration and would not recommend it if it wasn't a good option for you. But it is very encouraging that all these therapeutics are out there, and I'm hearing more and more people that are delaying the stem cell transplant based on that. So it's a hard call.
It's still new information for the community, right? And people are still trying to digest it. And it can make the decision a little harder, I think, taking everything into consideration that's known now.
I had a question for Jen. Did you, on your second transplant, so once you have your stem cell transplant, it takes another 2 years to get through all your vaccines. Did you have to go through all your vaccines again?
I did, yes. It was a day of shots. She just brought like this handful of shots out.
That's another consideration, because I thought when I was done with my stem cell transplant, I wouldn't see the doctors anymore for a long while, right? And then they go, oh no, you have to come back and get all your vaccines, and they're scheduled over 2 years. I was like, what?
I actually did it at my oncology office. I didn't have to go back down to the transplant because I did my transplants down in San Antonio. I'm also in Austin, so I did them here.
Alicia, what about you?
When I was first diagnosed, the first expert that I spoke with, he told me to go look around. There's so many new things out there. There's so many new pathways. There were so many clinical trials. I began looking around. I tried immunotherapy first, and I did not want all the other stuff. I only wanted immunotherapy, and I wanted it to end and not have all of these things. And unfortunately, my myeloma continued to progress, and my numbers continued to progress. And so as I saw the next specialist and the next specialist, well, my numbers proved it. And when they looked at it, they continued to say, you need a transplant. You need a transplant. And I didn't want to hear it. And I do think you have to listen to what the specialists are saying. We all want another, we want the cure and we want it all spelled out. Delaying it, they find some differences, and, what are you going to have to do in the meantime of delaying it? And like you said, it is a bleep in your life, and you get it done, and you can move on in a lot of positive ways. But maybe if you can delay it, and if you try that and it doesn't work, they can always go back to it. Again, there's no, and like you said earlier, I mean, there's just, everyone has a little different story, a little different time, the treatment. So sometimes you try to delay it, or even, get one right away, and then your myeloma decides on how it will go. And it's a very sneaky disease and works differently for all of us. I have never met someone who has the same story that I have.
Very true. It's a very complex disease, and it's different in every single patient. No two patients have the same experience, that's for sure.
So I think you really do have to, yes, go and get your consults and speak to the people, look at your caretakers in your life, look at your situation and your place in life, your time in life, your strength, your physical ability. There's so much that goes into the picture of choosing to have it now or to delay.
So Jen, let's wrap up with you. I know your case is a little bit different than everybody's because you've had two of them and you were diagnosed such a long time ago. But if you were diagnosed today, what do you think you would do?
I think I would do another one. Again, I just, I'm one of those people, like, if I can hit it hard in the beginning and just knock it out as much as possible, then I would totally do that again. I would much rather not drag it out over years of medication if I can help it. But again, that's just my choice, and everybody kind of has to go. Lynn said, it's so important to go with your gut, to do that research, and then just go with your gut feeling, because you know your body better than anybody else.
For sure. And it's so important to really determine upfront what your goals are of therapy, right? So Jen, there are people who are like you, they want, hit me with everything you got. I want to get rid of this thing and just give it to me. And then there are some other people who are like, well, I don't know if I want to do that. I don't want to be really sick for a really long period of time. I have some other things happening. My daughter's getting married. My kids are going off to college, things that they really need to have a little bit of space before they actually, become incapacitated for a period of time from something like this. So it really comes down to thinking about what your options are and making your needs known to your healthcare team so that you can decide together the best path for you. And that's really sort of what it comes down to. So I would really like to thank my guests today, Lynn, Jen, Alicia, and Suzanne, for sharing all of their amazing experience in myeloma and with their stem cell transplants. I think this is going to be a really great way for other myeloma patients to sort of understand the transplant process and the thought process that goes into decision making. So I think that you've done a great service to the myeloma community through this podcast, and I thank you for being on with me today. And I wish you all the best of luck and also the best of health moving forward. So thank you.
Thank you for listening to this episode of the Myeloma Matters podcast on autologous stem cell transplantation in multiple myeloma, hosted by the Multiple Myeloma Research Foundation. The MMRF thanks Alicia Wiggs, Jennifer Ansier, Lynn Chella, and Suzanne Wolfram for sharing their stories and unique perspectives on autologous stem cell transplantation. The MMRF also thanks AbbVie, Adaptive Biotechnologies, Amgen, Bristol Myers Squibb, GSK, and Janssen for their generous support of this podcast. If you have additional questions about anything you've heard today, please call the MMRF Patient Navigation Center at 1-888-841-6673 for more information.